Good evening, friends of the 60 Plus group. We are waiting for the facilitator to uh, complete his setting up, and then we'll start the program. Thank you very much for joining. Thank you so much. Prof, welcome. You can unmute yourself. We are giving ourselves another 3 minutes before we go live. So just settle down. Thank you very much. And you can unmute yourself as well. Thank you.
So you said additional 3 minutes. Okay. Thank you very much. Good evening, everyone.
Okay, Doc, we are just about to start now, so let me introduce you first, and then we'll be in business. Good evening, ladies and gentlemen. Welcome to tonight's session. It is part 2 of our discussion on the health of the heart. We had a fantastic discussion, and out of that discussion, we learned so many things about what we need to do with our hearts. It was very clear from the very lucid discussions, animated questions, and interest shown by participants in the meeting that we needed to do this second part. And so today we are carrying on with part 2 on holding your heart steady. This time we are focusing on what rational behavior do we need to observe. What kinds of medications do we need to rely on to avoid, and what specific health actions we need to do or avoid that can extend our lovely lives. Some of us on this platform are over 60, some over 70, some as old as 20, some as old as 40. But the heart does not wait for you. I believe you have to work on your heart at all times in your life. And the purpose of tonight's session is to give us a good guide on how to extend our life by holding our heart steady with good care. So once again, we are very, very privileged to have our brother and friend, Professor Joseph Atia Atama, who, as you see on your screens, is the Chief of Cardiology in the Meharry Medical College, as well as the Nashville General Hospital in the USA, and a visiting cardiologist to the Yaba Medical Services Center in Okonglo here in Accra. So on behalf of the entire membership of the 60 Plus platform, we welcome you to tonight's dialogue series, which is part 2 on the heart. So Prof, your audience is waiting for you. And as Prof is going to start, let me also say that we are also going to be streaming this on YouTube, so that after the session, if you wish to rehash the services that our dear brother is going to give us tonight, you can go to the YouTube and we'll share the link after the program is over. So Prof, you are welcome. And
thank you very much.
All of you to keep your microphones muted, and hopefully your videos also, except for the Prof, so that we can have enough bandwidth to give ourselves a very nice evening. So Prof, you are welcome.
Thank you, Mr. Yanka and Mr. Gatti, for giving me an opportunity again, and the 60 Plus platform. And I told you guys that officially this year, I'm part of the team of 60 Plus. So we're going to continue our discussion from last month, where we delved into various causes of heart disease and other things, and what we could do to help. This topic is a little bit different in that it says rational behavior, medications, and health actions to extend your life, which is really tough because it's God who extends our life. But we can do things to help Him keep us going. So I'm going to turn off my video so that I can focus. When I see myself on the camera talking, sometimes it gives me funny feeling. So
You feel
if you want to see my, you want to see, you want to see my face, I'll show my face later on. So please bear with me that I can go off the video for now. All right. So the last discussion, I'll just recap what we did quickly. So if you want to refresh your mind, we talked about the cardiovascular causes of our health, and then we talked about the causes of those cardiovascular causes. So our health most often is dictated by a lot of acquired conditions. If you look at the box here, it tells you how much representation of these causes entail. So the acquired conditions really are things that we can prevent potentially. Potentially, we can prevent in that if you're eating badly, you're drinking a whole lot, these are things that you can go for help. Sometimes you cannot help yourself, so you go for help, counseling, and rehabilitation that can help you. The inherited conditions, unfortunately, it runs in generation from generation to generation. That one you cannot stop it because you inherited it. There are other causes which are not too many, but we see them in frequency when there are a lot of environmental problems. Maybe a mother became ill during pregnancy or took some medication during pregnancy, and they'll give birth to a baby that has a defect. Sometimes there's no reason. It's just the baby's formation. There wasn't any completion of the formation of the heart or the brain or a limb. Then they get born with a heart or limb defect. But most of the causes are the acquired socioeconomic, behavioral, and environmental risk factors. Some of them you can't do anything about it. Even though you acquired it, you can't do anything about it. You're getting old, you're getting old. You're born a man, you're born a man. If you're a woman, there are certain conditions that may affect you that will not affect a man. Ovarian cancer cannot affect a man. Cervical cancer cannot affect a man. Similarly, prostate cancer cannot affect a woman. So those are age, gender, family history, ethnicity. You can't do anything about. Okay. However, the modifiable risk factors you can do something about. You can detect them and then take care of it. Let me I'll change it to a right pointer. So modifiable risk factors, high blood pressure, cholesterol, weight gain, which leads to multiples of problems, including obstructive sleep apnea, arthritis, problem with body habitus, mental disorders, depression, and isolation. It's a big problem. Physical inactivity, diabetes, high sugars, these are things that you can control, modifiable. Infections, sometimes you can control, like controlling mosquitoes from getting into your house. But unfortunately, there are certain conditions you might not be able to control that much, and they can affect your heart. So sore throat with strep throat can indirectly affect your heart, and later on in life, a person may be suffering from rheumatic fever related heart condition called rheumatic heart disease. Syphilis, even though it is affecting a localized organ, can be systemic and affect the heart. It causes valve problems, it causes arterial problems. Certain parasites can find their way into your heart and cause problems. Obviously, we know by the recent events, COVID vividly visible. If you can remember the isolation, people had problems with their heart, and people are still having problems with their heart. So whatever it is, these cardiovascular problems lead to disability. Okay. You like to think of stroke as a neurological problem. It is not. It is a cardiovascular problem that affects the neurological system. So it's a cardiovascular problem in all its totality. The way the stroke happens is all cardiovascular disease. It leads to disability, heart failure, obviously, the person is going to be disabled, kidney failure, apart from few instances where kidney trauma from toxins and other things like galamsey leading to toxins can cause kidney failure. By and large, hypertension is a very strong contender when it comes to kidney failure. So in a way, it's a cardiovascular problem. And the funny thing is, kidney failure itself affects blood pressure. So it's like the egg and the chicken, which one comes first, right? Dementia, obviously, when one is demented, cannot think well, cannot focus, cannot remember things. Most of it is due to cardiovascular problems. And men know this too well, that this is one of our most fearful diseases. No man wants to be labeled like this, and no man obviously wants to be impotent. So it's a disability. You may not show that you can't walk, but mentally, the person is very disabled. And it can lead to death in actual fact. So we talked about prevention being better than cure. And I made a liken to refuse in Jesus' name and accept in Jesus' name. And I'm hoping that the malams and then the priests amongst you will not take me to court. But the truth of the matter is, when you want to do primary prevention, you pray to Jesus and Allah to help you prevent that condition from coming to you. But you have to do the right thing. That's the thing. You have to ask God or Jesus Christ to help you maintain a healthy lifestyle. Exercise. Don't smoke. Don't drink. Unfortunately, sometimes you do all your best and the condition will still come on you. That is not the time to start praying to Jesus to refuse hypertension. When hypertension comes on you, the more you pray, the more the blood pressure goes higher. So at that point, I'll say accept the hypertension in Jesus' name and then ask Him to help you control and contain. That is how we should look at it. And I believe the pastors will start preaching this in church. Otherwise, we're going to be going around in circles, not understanding what non-communicable diseases are. And to date, I'm not sure whether they've changed it. To date, in Ghana, non-communicable diseases causes most of the death in adults. And guess what? It used to be a unit. I'm not sure it's still a unit. Most of you who have been in the civil service and government system, a unit is useless. Non-communicable diseases kills most Ghanaian adults. Non-communicable disease is a unit in the Ministry of Health. I don't know if changed it. I made noise. I said you cannot keep non-communicable disease as a unit. You have to blow it up, give it its own unit or department, and let them handle this carefully. And so, if you're going to rely on the government to take care of non-communicable diseases, know that it used to be a unit, and I think it's still a unit. And we should encourage the government to move it to a whole department because most of the adults in Ghana are dying because of non-communicable diseases. Okay, enough of that. Let me talk to my people. The goal is to add life to your years, okay? Not just years to your life. And so you must know these numbers. You must know your glucose level. You must know your cholesterol level. You must know your blood pressure. The ideal blood pressure should be what it used to be when you were very young, 120 to 130, 70 to 80. And usually it's lower in women. So when it starts to cross this number, takes care that it can be controlled. And then we talked about the fact that you should start something. So how many of you have started something? Mr. Yanka, did anybody tell you that they have started doing something since we last spoke?
They don't want to commit themselves by lying.
All right. So today, let's talk about what else can we do if we want to live long. So the paradox is you have so much time, but you're also limited in risk. All retirees have ample of time. You used to get up 6 o'clock and start rushing to work. Some of you way beyond before 6. I remember when I used to drive from Pillar 2 to Korle Bu, I had to get out at 5, sometimes 4:30. If I don't, I can't get to Korle Bu early, and I wanted to be there by 7. So the opportunity of longevity, more time for your family, hobbies, take care of things that you couldn't do, personal fulfillment, you want to enjoy your life. And sometimes some of us over-enjoy, and then we eat too much sugar and become diabetic. It's another topic we will save for another day. But freedom from workplace stress and strict daily routines, you are your own boss, a chance to design a vibrant, intentional second half of life or even third half of life. But at the same time, you are challenged. The waist is no more allowing you to be flexible. The knees are paining you. Your arteries are stiff. And then your heart is becoming weaker. Your muscles are beginning to frail and fail. And so the activities you could get up and do those days, you cannot. So always give yourself time. If you used to walk 30 minutes for a mile, now that you are 80 years, maybe you should give yourself time. And the body becomes less forgiving of poor metabolic choices. So don't, young people can eat anything and then get up and go, right? But as you get older, things become really tough. Protecting your health transition from option into a daily duty. You're on duty all the time. So that's the first thing you have to do. You tell yourself, I am on duty for myself. Your ADLs will start changing as you age, and you have to adjust them. ADLs are activities of daily living. You have to start cutting your coat according to your size, decongest your rooms. All the nice things you have in the rooms become useless when you become 80. You need space to move. You need space to see. You need light to see. So you have to decongest. So pillar 1, rational behavior and mindset. Acknowledge vulnerability. Move past the illusion of youth. Recognize and accept that your cardiovascular profile changes with age, allow you to act logically instead of emotionally. And if you don't take this at heart and truly believe that you're no more the Superman or super spaceman or invincible man or woman, things can get into clashes. You start having emotional clashes with your own image and other things. Like the old lady who just passed, the music icon, she told people, I believe in myself. No matter what, I'll wear my wig, right? So that is who she is. She didn't hide it. So you have to believe in yourself and say, this is who I am. I need to use this to look better, or I need to do this, use my cane and walk properly. Manage your stress intellectually. Retirement brings new emotional patterns, loneliness. Your children are all gone abroad. Your children are in Tamale and you are in Accra. You want to be in the village, but your children are in Accra. So you move to Bongo. You're the only one in Bongo. Because you didn't live in Bongo for a long time, you're isolated. Okay, so you had to start thinking, how am I going to deal with this? Counter modern stresses using deliberate relaxation techniques. forming groups, meet often with friends or new friends. Ditch the invisible myth. Okay, symptoms are biological data. Symptoms are telling you there is something going on. Okay, not that you are failing. So when you go to a doctor, don't say, I think it's all age. Just tell the doctor what you're feeling. And then we can analyze and help you come up with. And don't settle for, oh, I think it's all your age. Some doctors do that too. True irrationality means seeking clinical advice immediately when something unusual is happening to you. Mastering your medications, you're not alone. You're not alone. Turn around, somebody has 10 medicines. You only have 2. Turn around, somebody's injecting himself 10 times a day, and you only take 1 pill. Polypharmacy worsens by multiple doctors. And sometimes we want to hide from the doctor that will see another doctor. So when you come to me in my clinic in Ghana, I always ask, who have you seen about this condition and what did they tell you? So you can't hide it from me. And most of the cardiologists, most of them are trained. Those are didn't train, they're my colleagues, and I train them in one way or the other. So I'll ask you, what did he tell you? So if you're coming to shop here, you have to reveal yourself so that we can take care of you. Okay. Avoid hopping from doctor to doctor. Ask questions, Google your medication, send it to your children to search the medication. And look at the various medicines you are taking. Each of them, if you have a piece of paper, let the doctor, if it means sitting down and pay him extra to write it, if it has no time, corner him at a time when he can write it down for you. What is this medicine for? It's for cholesterol, to bring my cholesterol down. And you write the number he's looking for. And you know your number. Blood pressure, what is it for? How many medicines am I taking for blood pressure? Okay. Sometimes the medicines can be used for multiple reasons. So a blood pressure medication could be used for your heart. So a patient comes in with heart failure. I start a medication. They call me. You gave me a blood pressure medicine. I say, yes, it was for your heart, but it's also used for blood pressure. So beta blockers, ACE inhibitors, all of these have side effects. They interact with each other and they can cause problems if you don't tell the doctor and you get multiple medications. Diabetes care has a lot of medications, right? And it keeps the sugar controlled. But these days, I can hardly keep up with the different medications for diabetes. And each of them comes with its problems. Arthritis, definitely as we're getting older, we'll have problem with arthritis. They come in gels, they come in patches, they come in pills, injections, you name it. And each of them can interact with your other medications. There are a whole lot of other medications I wouldn't list here, but remember you need to know the specific reason you're taking the medication. Never alter or skip doses if you can. So as you get older, put a pill box. Pill box, you will never tell lies from a pill box because you know it's a Monday to a Sunday. Monday still has 3 pills. That means that you didn't take them because you walk out, you've forgotten that you're taking your pill. You're not alone. A lot of people forget. So, but if you have a pill box, you're not in a nursing home. No, you just want to make sure you can take care of your medications. Review with your doctor all the medications you're taking, and then ask him which medicines you think are not necessary now. You've been taking stomach medicine, ulcer, for 10 years. Why are you still taking it? Okay. Do you need to be on that pill? When you're young and the director of procurement, you were meeting people in their beer bar and you were drinking, and you needed to be on uric acid medication because your uric acid was high, you're getting gout. You are now 70 years old, you don't drink, your uric acid is 0. You don't need to take the uric acid medication that much. Check it and make sure. So some medications by default need to fall off your list by the year. We have seen a lot of medications being sold here and there, cardiac medications, and they'll tell you that that's the best medicine. The person would have been a billionaire, and they are actually billionaires because you bought the medicine or we bought the medicine. But the medicine is not working. Otherwise, the whole world would have been taking that same medicine. Well, then when they brought this food supplement, it was like that was the panacea of all our troubles. Guess what? We made people millionaires, but the problems have not changed. So anytime somebody is peddling a medication, ask yourself, do I have extra money to give to this guy to become a millionaire? That's the first question. If you don't have extra money, don't go there. Better go cut your neem tree and chew on your neem stick. It's better than you giving money to somebody. He becomes a millionaire and you're still going to be the same. So what are the things that our medications can bring? Side effects, adverse reactions, drug interactions. So these are, every medication has a side effect. Some might not be revealing, but every medication has a side effect because a chemical that's entering you. But whether you respond to it or you react to it is a different matter. I might give you a certain dose and you'll be up and walking. I give the same dose to another person, the person will be down for 3 days, cannot walk. So everybody is different. And so side effects usually are written. The company will tell you these are the expected side effects. Okay. Common reaction to the medication, they're usually anticipated beforehand. And for instance, you take over-the-counter medication like our good old Piriton, you expect to be drowsy. And then you go to sleep. So if you take it during the day, you don't drive. Other you have problems. So that's an expected side effect. How about adverse drug reaction? These are harmful, unexpected, or severe reactions that occur even when a drug is taken correctly. So sometimes it's unpredictable. Okay. Sometimes it's dose related. The higher the dose, the worse the adverse reaction becomes. So developing a severe skin reaction or suddenly falling due to dizziness. So some of these medications can cause this. How about drug interaction? So like chemistry, if you remember, most of you are engineers, you remember your chemistry, chemicals interact. So if you take a base and an acid, there's going to be interaction. So some medications obviously will have interaction, but usually it's not like a chemical reaction, but they amplify a side effect or they come together and cause a problem. Okay. So for instance, when two or more substances clash, altering how a medication works and making it dangerous. For instance, if you take a blood thinner and you take aspirin at higher dose, that can cause a lot of bruising. That can even cause bleeding. If you take antibiotics and you also take medications like warfarin, which is a blood thinner, it can cause problems. If you take antibiotics and then you also take medications for nausea, that can give you rhythm disturbance and can cause you to suddenly die because it causes prolonged QT and that can cause rhythm disturbance. So there are certain signs of bad heart, medications or general medication. Yes.
Prof, before you go on, what you said it causes QT. What is QT for non-medical people?
QT prolongation, an ECG would maybe another topic would be the heart test would do. So I can show you what an ECG is like. But on the ECG, there are various sections of the ECG. So a complete cardiac cycle contains various sections on an EKG or ECG. You have first the current. You guys are electrical, most of you are electrical engineers. So there's a current that generates automatically from the top portion of your right side of the heart. And this current, it gets directed downwards to help your heart contract in a unified fashion. Now, during this cycle, the portion of the heart electrical activity where the heart is trying to recalibrate and start another pumping action, that period is called the diastolic period. And part of it is a QT, where the heart is very, very sensitive to tiny sparks of electrical current or disturbance. So it is the portion after your heart contracts the blood out, and then it is trying to recalibrate, restructure itself, relax, and then get a new electrical activity. That portion, the heart is very, very vulnerable. That's the portion called QT. The longer it is, the chance that something may happen. And what may happen? An electrical disturbance, potassium or sodium misfiring, a spark might just set up bushfire. And so at that portion, if it's too long, that QT is too long, the heart can go into rhythms that are very terrible, like ventricular tachycardia, ventricular fibrillation, the worst one, or torsades and other things like that. So if you, the next time you go for an EKG, ask your, or ECG, talk to your doctor and say, hey, show me the QT. But the next time, I may talk about heart tests and what to expect and stuff like that. So we can talk about this. But QT prolongation is very serious. So if you take multiple medications, I'll give you the example, and certain antibiotics. Example of an antibiotic that can prolong your QT is azithromycin. Azithromycin, we don't like using it too much on the old patients because the QT, because you're on, the person might be on so many medications, and then we'll add azithromycin and it can cause problems. So that is one example. I hope it's sitting well. I know it's tough to describe certain medical conditions, but the ECG has various portions, and the QT is the most sensitive portion of your heart period, during which a tiny mistake can lead to a serious rhythm disturbance. Okay. Mr. Yanka, is that okay?
Perfect. I
Okay.
can now write my medical school exam.
All right.
Perfect.
So,
Thank you.
hidden signs of medical and medication trouble. Older adults process medications differently due to natural changes in liver and kidney function. In retirees, a bowel reaction might not look like a typical rash or stomach ache. So watch out for these, sudden confusion, especially if they change the medication and the person comes home and suddenly the person is behaving funny. Attack the medication. Stop it and call the doctor. Yes. Mr. Ghani.
I see a hand up. Richard,
Yes, Mr.
send this up.
Ghani raise his hand.
Yes. Mr. Ghani, kindly unmute yourself, and then otherwise we'll hold your question till Prof is finished.
Okay, he lowered it. All right. So anything that is unusual usually happens when there's a medication change. You go to a new doctor, he didn't realize that you're already on so many medicines, and he asks more medications. Unsteady walking, extreme daytime sleepiness, which is not your usual self. Start thinking, am I taking a new medication? Or the medicine, sometimes some of these side effects can happen a week or two later because it accumulates in your system and because of the problem with kidney clearance and liver clearance. Unexplained bruising. Sometimes it could be due to your blood levels that are different, but if you're on medications, that can cause bruising. Think about that. So, strategies: keep a complete list of your medication. Conduct regular audits. Talk to your colleagues. Maybe they've taken that medication previously and the doctor had to change it. And remember, the fact that I reacted to something doesn't mean that you also react to something. But it's always to exchange notes so you can know what is going on. There are guidelines that are set for you to compare medications and see what is going on, especially as you age. Ask the right questions. We don't like asking questions in Ghana, and the doctors don't like us asking questions, but they are changing. So most of the doctors I help train, I told them you have to allow them to ask you questions. So ask questions, but don't be too known. Sometimes, if you're not prepared and you ask too many questions, the doctor feels you're too known. But ask the appropriate questions, write them down before you forget, because you have a question at home. By the time you get to the doctor's office, that question has vanished. Okay, so write it down and bring out your list. And please bring the list out quickly before the doctor spends 1 hour. Then now you bring the list. By that time, he's becoming irritable because he has already spent 1 hour with you. And now you are bringing your list out. So bring the list out. Let him see that you have a list from the beginning. Then he can go through and then help you out. Avoid internet remedies. Try to talk to your doctors and your children before you take any medications. High risk drug interactions. So we talked about the drug interactions, and I mentioned the antibiotics and other things, but these are common ones: opiates and benzodiazepines. You're taking pain medicine for your back, and then somebody gave you a sleeping pill. That's a no-no. So it can cause a lot of problem. Tramadol, and then or Doretta, and then somebody gave you something to sleep. The interaction can make you really, some people actually go crazy with some of these interactions. We mentioned blood thinners. Be very careful. The newer agents, like I'll call their pharmaceutical names, that mean that they cause problems. Xarelto, Eliquis, these medications are newer. They've mostly replaced warfarin, but they can also have problems because they make your blood so thin that if you take ibuprofen for pain, you can erode your stomach and the person can start bleeding. Okay, aspirin. Or they'll make you bruise very easily. Warfarin and certain antibiotics. Fortunately for us, warfarin has become very rarely used. Only few people use warfarin, those who are on warfarin for serious blood clotting problems. That medications cannot stop the blood clots. Warfarin is the best. People who have mechanical valves, artificial mechanical valves, warfarin is the drug to use. But it can interact with antibiotics. Some antibiotics will make it overwork. Some antibiotics will make it underwork. So always cross-check with your physician if you're put on warfarin. But as I said, it's becoming a less common medication. Antidepressants and migraine medications can cause problems. It can cause toxic buildup of serotonin in the body, leading to potential life-threatening conditions called serotonin syndrome. So remember some of these medications, talk to the doctor. So you saw your family medicine doctor. He put you on antidepressants because something happened in the last 6 months, you can't sleep, and it thinks you're depressed. But you're also seeing a neurologist who gave you something for migraine. You have to make sure that they are not interacting. ACE inhibitors and potassium, make sure your kidney function is checked regularly, and the physician has to check the kidney function. ACE inhibitors and spironolactone, ACE inhibitors and potassium supplements. Sometimes you're taking a potassium salt, not losartan potassium. Losartan potassium does not cause high potassium levels. Losartan potassium is a compound. The losartan medication is compounded with potassium. That's why it's called losartan potassium. But medications that increase potassium, like the spironolactone, if you combine with ACE inhibitor or losartan ARBs, that can cause potassium to be high. Why are we afraid of potassium? It can also lead to rhythm disturbance. So high potassium is very, very dangerous. That's why in countries that still kill people who are bad, they use potassium because that lethal injection stops the person cold immediately. So it's a leading cause of cardiac arrest. All right, serious drug side effects. As you read around, you'll come across these. Anaphylaxis, these are very terrible reactions. Stephen Johnson, we always fear this medication and this side effect. It's unpredictable, and so it can cause serious skin problems, and it's almost like global skin burn. The person loses a lot of fluid and may die from that, and infections and other things. So it's a serious problem. Hives can occur with certain medications. Some people react to ibuprofen and aspirin, and some people wheeze with aspirin. Bleeding, we talked about the drug, blood thinners, NSAIDs, ibuprofen. So as you get older, avoid most of the brufen, diclo. Don't use them if you can avoid them. Okay. Organ damage, liver toxicity from paracetamol. That is very common. So as we get older, we want you to take paracetamol. We don't want you to take ibuprofen. But if you take too much paracetamol, then it can also cause liver trouble. And if you take paracetamol and you drink wine, then you cause more problems. So always think about your liver when you're taking medications. Kidney injury can occur with ibuprofen, diclofenac. All of those pain medications can cause kidney injury. There are other medications that can cause kidney problems too, that can lead to problems that may not reverse. So there's actually a condition called the secretary's kidney, where secretaries take a lot of ibuprofen because they have period pain and they have waist pain because they are sitting down serving their bosses for so many hours. And by the time they get to 50, 60, they get kidney trouble because of the pain medications. Brain and mental changes obviously can occur, and then you have heart trouble. These days, there are so many new medications in the world that are attacking the heart, especially the newer agents for rheumatoid arthritis and scleroderma and conditions that are very terrible, that used not to have treatment. These days, they have treatment, but the medications can cause side effects. Cancers used to be terrible. These days, the cancer medications are very good. They attack the cancer, but they also attack the heart. So it's not uncommon to have a cardiologist see somebody on cancer medications. Pillar number 3, we're ending it soon. So strategic physical activity, negotiable health actions. Think about what you can do to prevent all of this from going down the hill. Take action. Remember the last time we said do something. Target 150 minutes of moderate aerobic exercise weekly. So if your week is 5 days, divide it. If your week is 7 days, divide it because you have so much time. But most of you, Friday and Saturday are already taken, right? Because you have to go for that funeral. And then Sunday is taken by the church. So if you go to the funeral, you go Friday, then you go to the funeral, and then Sunday you go to Thanksgiving. So that weekend is gone. So literally you only have 4 days. And by the time you come back from Hohoi or from Bongo, you're exhausted by your age and the travel. So you only have 3 days. So try to minimize some of these activities and focus on your health. Okay. It's a reality in Ghana, but you have to think about your health too. We talked about this last time. I told you about the steps you should take. The ideal thing is to go higher steps per day. Make sure you're very active per day. But the best one is to walk in a straight line, if you can, 1 mile and back, kilometers and back. If you can do that, that gives you a lot of exercise to your muscles and a lot of exercise to your heart. Because your heart also needs exercise because pumping fast It's an exercise for the heart. So when it does that, it keeps the circulation going, and then it's more agile. That you need it at a certain time, it will wake up appropriately. Find your baseline, track your normal daily steps for a week and see what you're doing. Add 500 steps per day and build up your stamina. Don't go running when you've never run. Take it slow. And you can get a trainer, but make sure you have enough money to pay them, because the trainers come in with a strategy. They're not coming to come and do it 1 week. They're coming there for 52 weeks or a whole year. So you have to have time and money for them. Pillar number 3, again, non-negotiable health actions, cardioprotective nutrition. Our food, what can we eat that will give you the best protection? What to remember is, as you get older, your digestive system is no more what it used to be. So try to cut back on too much meat. And you've eaten too much meat. When you're the board chair, when you're the director of procurement or wherever, you eat so much meat. So when you're 70, cut back on the meat. Do more fish, dry fish, roast it or grill it. And that is what you should be doing more for your protein. Do a lot of plant protein. Of course, some of you and some of us will have a lot of gas with beans, but who cares? You're alone in your house. So eat your beans and get your protein from that. And then physical activity, be outdoor. Do a lot of family meetings. Okay, interact with your family. Take walks. If you don't have a dog, walk with your wife. If you don't have a wife, walk with your husband. If you don't have any of these, get friends you can walk. Very active lifestyle keeps your boredom down. And then you look at the type of meals you eat, cut down the quantity, but eat more frequently. Light soup is very good. I always tell my wife does this super light soup, and I say, anytime I'm hungry, I want that light soup first. And it is combination of all kinds of things. It comes out so good. And sometimes she does a thick, and I like a thick, I call it thick light soup. It has everything. So when I drink it, it's so good. You can increase everything in your light soup, okay? And it becomes really good. So sleep architecture should be very good. Make sure you can sleep very well. They say 7 to 8 hours uninterrupted. But as you age, there's no way you can sleep uninterrupted, right? You have to get up, turn around, go and urinate, come back, go and urinate. If you have prostate problems, forget about it. If you have diabetes, another trouble. So, but make sure you rest very well, okay? And then look for things that can prevent you from sleeping. They can also cause, because you don't sleep well, it might cause some problems. The other thing you should think about is, and we mentioned it, we gave you the numbers. Keep a record of your last blood pressure and your regular blood pressure. When it changes, you'll be able to tell. Your last sugar, make sure you know what it is. Your A1C, your cholesterol. And then there are other things, kidney function, which usually the doctor will say your kidney function is good, right? Or your liver function is good. But ask specific numbers. So numbers in the liver function that you want to know is the albumin. What is your albumin? What is my albumin level? What is my liver enzymes? Are they normal? What are the numbers? So when they start to go up and the albumin is dropping, you know there's something wrong, right? Hemoglobin level. Some of these things may not be so obvious when you go to a doctor, but if you ask for them and write them down, you can have a log that can keep you. So to conclude, prepare for every visit you see a doctor, because you have too much time. You saw him 3 months ago, so start writing things down. Send him information. And then by the time you're ready for your appointment, you're ready. Okay. Remember, he also has 20 patients to see the same day. So you're not taking the whole time. I wish patients could buy 3 patients' time, but that would be illegal, right? So you can just buy 3 patients. I bought your time for the next 3 patients. They can, you can just see the doctor for the whole day. But that is not allowed because he has to also be judicious with his time and equity. So you don't also want to occupy the doctor the whole session. But be very good with your preparation. Ask pointed questions. Demand clear answers. What is my current cardiovascular risk score? It's not a bad question to ask. If he doesn't know, a good doctor will say, look, I have 20 patients waiting. I'm going to write this down. Give me a call tomorrow and we'll talk about it. He might not say, I don't know it. Maybe he doesn't know it, but he will calculate and then get back to you. Okay. These days, you don't have to ask the doctor. Just go in and say, how do I calculate my cardiovascular risk? Put your age, and then something will spit out. Now you can take it to the doctor and say, this is what I got. Can you help me understand what it means, right? Are these numbers optimal or just acceptable? And then bring a health advocate. If you forget a lot, which most of us are beginning to do as we cross 60, either by so many things on our mind or real problems with the brain, send a trusted family member, a friend, okay? And then have them ask questions, help you understand. Never leave a clinic with a prescription without knowing exactly what that medication is meant for. That is very, very important. Very important. So I would say holding your heart steady is an active choice, combining logical habits, precision, medicine, and daily discipline. Medications are not a bad thing. Yes, I prescribe them, so I'll say that. And I take medications. I take medications myself. I forget sometimes because I'm a human being. But if you view them as all having side effects, then you're going to be containing symptoms that should not be there. You may be having worsening conditions that should have been gone. You may be having complications of your cardiovascular disease that shouldn't have happened because you decided to go for side effects. Avoid falls and injuries. That is a key point. In Ghana, a hip replacement is so expensive. You won't believe it. If you're lucky and you invested well, you pay for it. If your children can afford it, they'll pay for it and they'll grumble because you just may set them back 20 years. Or you sell your village cows and then repair that hip. Avoid psychological trauma. My dad wanted to marry, bless him, he's still alive, walking out. He wanted to marry at some age. I don't want to think about it. We all had to stand right in front of me and tell him that if you bring this trauma to this house, you're out. So don't go marrying when you're not supposed to marry. Don't go chasing young men when you're already old. Don't go looking for young women when you're already old. That's psychological trauma. It's going to cause trouble. Okay. But of course, men and women are always going to be men and women. We're not saying that you shouldn't do certain things, but remember, avoid psychological trauma, avoid all the unspoken mistakes that people have been talking about. Be ready for lonely days and nights. Okay. So as we get older, we may lose a partner, which is unfortunate. Or the children will all leave, just like you, the way you left your dad in the village and came to the city. It's the same way. They're going to leave. And if your children are abroad, that is even hundreds of miles away from you. It has to take a visa, and then you have to pay American embassy or German embassy or Canadian embassy, and then you take the plane. That money you could have used to buy a lot of rice and stuff. But you have to go visit them. And then when you get there, they don't have time for you because they are working 24/7. So the loneliness even compounds when you go to abroad to visit. They may get time for you for a weekend, but that is it. For the rest of the time, we brought my dad to Chicago, and he got a friend who was very old next door, and he was speaking Frafra, the woman was speaking English. I don't know how they understood each other. But he said the place was boring. He wanted to go. My mother-in-law came, the place is boring. So that means that we're better off in the village. So build your village. As you're starting to retire, go back home frequently. Get a system in place. So when you get back, you are not a lonely person. You can interact with the people. Don't go looking for chieftaincy when you've retired. Unless it is your time, those things are very traumatic and they cause a lot of problems in your health, in your money, and in your family, and can leave a bad taste for your children and generations to come. Declutter. Decluttering does not just mean collect your things and throw them away from your room. Declutter your mind, the responsibility. Try to narrow down your responsibilities. Okay, delegate responsibility, and then obviously in your house, take away unnecessary things. Most of us are hoarders, and then we leave them to, then you want to move, you don't have the agility to be jumping over things. So let them clear them. You don't need them. Your children may not need them. So get rid of them. Retirement is your reward. Protect your time by protecting your health. I'll end here and we'll take questions. We did a little over 1 hour or nearly 1 hour. Thank you very much, everybody.
Wow. Thank you so much, Joseph, for this wonderful heart discussion. Before I open the floor for questions, in the chat room, there is a quick question. Let me read it. It says, what is happening if BP readings are as follows? And he's got 132, 77, 82, 134, 79, 78. Age is above 73 years, and the patient is on Cavidian 6.25 milligrams and the Santin 50.
Okay, yeah, so the numbers look good. I would say well done. But you have to also give me some detail. When are these blood pressures taken? The 132, 77, 82, is it in the morning before you take the medicines? The 134, 79, 78, is it in the morning before you take the medicines or after the medications? The 115, 73, 80, is it in the evening when you come back from work or your normal activities? 107, 59, 82, 80, these are acceptable, but it depends on the frequency. So I'll just elaborate on it quickly, then you can type in your response or send it to Mr. Yanka or Mr. Gatti. They'll send me. Basically, when the person has these numbers, I'm happy. So long as the majority are not in, let me see if I can, let me copy his question so you guys can see. I'll copy it and then see what I can put it on the.
You have to go to
regular
mode.
Yeah. Okay. So basically, his numbers are not bad at all. They are not bad. And I'll put the question right here because it's a very good educational point that I wanted to make. Let me make it this way. Yeah. Okay. So this is his question. I'll share it in a minute. Let me see. Where's the share? So this was his question. Is it clear? Can you guys see it?
Yes, it's come now.
Yes. So what is happening if BP readings are as follows? So 132, 77, 82, 134, 79, 78, and then 115, 73, 80, 107, 59, 80. So I'm assuming this machine gives your blood pressure as follows. Correct me. Systolic is 132, diastolic 79, your heart rate is 82. That's how normally it comes out. But some machines could be calibrated differently. So this is systolic 134, this is diastolic 79, this is your heart rate. So in a way, your heart rate is about the same. Okay, 82, 78, 80, 80. If that is your heart rate, it is steady. Now, what is not steady is the top numbers are higher than the bottom numbers, right? In that 132 is way, maybe twice, about 15 points higher than 115 and way ahead of 107. So it depends on when you took this. If you take your blood pressure 3 times in succession, so 2 minutes apart, you take it, wait 2 minutes, take it again, most often the blood pressure drops by the 3rd reading or the 4th reading. So your first number is always high. Second thing is, if you take this blood pressure in the morning, I'm very happy with it. This is good. If you got this number in the evening, this is also excellent. It's not too low. It's a little bit low for a 73-year-old, but not too low. Now, if you told me 90% of the time your blood pressure is staying in this range all the time, occasionally here, then I say let's adjust your medication, okay, so that it can bump up a little. This is a little bit too low. Remember, the number we're looking for is 120 to 130 over 70 to 80. So your numbers are within points. Now, this could be 2 hours after you took the medications. Okay. If you did that, this is okay. But it will bounce back up again because your morning blood pressure was high. Then you took it 2 hours later, your blood pressure went down. But if you are symptomatic, your blood pressure is, you're feeling dizzy, you're feeling tired all the time, and your blood pressure is staying in these numbers, let's adjust the medicine. So I would say, without knowing when these were taken, just looking at them for a hypertensive on just 2 medications, I would say this is good. But so look at the frequency. How often are you getting these numbers? And what are your numbers early morning before anybody disturbs you? Okay, you get up in the morning, go and sit on the dining table or by your bedside. Don't walk, wait for 5 minutes, check your blood pressure. What is the early morning blood pressure before the day's activity begin, before you take your medicines? That is very key. What is your blood pressure when you're settling in? Around 4 p.m., 5 p.m., you come back home, check your blood pressure. How low is it? Because you're dehydrated. Remember, when you're up walking, you might be dehydrated. And also remember, activity influences your blood pressure. So when you walk and sit down, the blood pressure might be too high. So always wait for about 5 minutes. I hope I'm able to answer his question. But I like the combination. The blood pressure is good. The heart rate is a little bit high. I'm being technical now. So don't take it too serious because the carvedilol is probably once a day. Okay. The carvedilol is supposed to slow down your heart rate. And so I was expecting maybe you're not taking it twice a day, but if you're taking it twice a day, carvedilol can bring down the heart rate to the 70s to the 60s. But this is not a bad heart rate. It is good.
Thank you very much, Joseph, for this wonderful question. So we have really gone through a whole lot of discussion. I think that today, focusing on the rational things to do, rational behavior, and so on and so forth, it's been very good. That has warned us about several things. in particular, that we need to be careful to understand that even non-communicable diseases can have an impact on our health. We talked about the linkage between glucose levels, cholesterol, and so on and so forth, and in fact, activities of daily living. I think one thing that struck a huge chord in my mind was the fact that we like doctor hopping, and we also like polypharmacy stuff. And so avoiding these two were key things that we mentioned. And of course, the discussion on medication and this effects, both the side effects, I believe we talked about the adverse reaction and also the interdrug interaction. And the one that took
Okay, I think his mic is off. Can you hear me?
Yes, some of us can hear you.
Okay. The person said, thank you. Any other question, you can unmute and ask whilst we wait for Mr. Yanka to come back. Mr. Gatti, did you have a question when you raised your hand earlier?
Can I say something?
Yes, please.
I also want to know what happens when you take your medication correct, you do the necessary exercise, you eat, you eat well, and it's still your BP is always high.
Yeah, so we didn't go into details about the various causes of BP, and we didn't talk about what else to do when scenarios like this happen. Sometimes, most of the patients who have blood pressure need combination of medications. Sometimes certain medications work better for certain people, other medications work better for other people. So if the medicine has been taken constantly, regularly, and you're doing the exercises, you're watching what you're eating, you're not drinking too much, maybe the medicine is not a good fit. That's number one explanation. Two, the medicine dose is not enough. Three, you may need a combination of medications. Four, your blood pressure might be. What do I mean? Majority of people, we don't have a cause for the blood pressure. We know it is lifestyle, it is you eating too much salt, it is you being a black person, it runs in your family. But we can't just say that this is what caused your blood pressure. That is majority of people. So we call it essential hypertension. And the funny name called benign hypertension. I don't know who came up with that name, benign hypertension. It's not benign, it is serious, but let's say essential hypertension. So that is, we don't know the cause, right? In a few patients, we call it secondary hypertension. There is a reason. And sometimes when we take care of that reason, the blood pressure vanishes. Okay. So if the blood pressure is too high and you're doing everything, talk to the family doctor, say you need to see a specialist. Sometimes the family doctor is overwhelmed. He has 200 patients on one day. So to really concentrate and come up with the plans to find out what type of blood pressure you have might not be there. So I think first thing is to sit down with a doctor and say, do you think these medicines are working for me? Maybe I've been on them too long. Can we change them around, get some newer medicines? Make sure the medications are credible. Sometimes we buy medications that are not credible. Secondly, check your kidney function. Is your kidney function good? Thirdly, ask the doctor, do you think I have secondary hypertension? The doctor say, oh, forget about it. What do you mean by secondary hypertension? But secondary hypertension is when there is a real reason why you have the blood pressure. And the secondary hypertensive patients are difficult to treat. They don't respond to medications easily. So do the elimination. First, continue what you're doing, which is good. Avoid alcohol, which is good. decrease your salt intake, relax, take care of your business. The minimal involvement of with stress, the better. So avoid stress, and then talk to your doctor. Most often, we will change the medication, check your blood test, make sure that everything is okay, and then we can move to the next level. If it's not getting better, then we'll have to go to the next level to see, do you have kidney injury? Do you have secondary hypertension? Thank you.
Yeah, I also have a question. Can I ask?
Yes, please. Is Mr. Yanka back?
I don't think he's back. He's
Yes,
not on
yes, yes.
Oh, okay, he's back.
Okay.
But the Vera's hand, before you go on, Ben, Vera's hand was up.
Okay. Thank you, Doc, for the all the education. Yeah, it's very insightful. But I have a question. Do you incorporate inflammation testing in like routine medical screening? Because we all know inflammation is the driver of most of the chronic diseases. And typically, they actually will screen for a comprehensive metabolic panel, which doesn't give you the bigger picture. But with the inflammation markers like high sensitivity CRP, and you even mentioned the cardiovascular risk calculator. So here, you can even factor in the coronary artery calcium score.
Exactly.
Because the reason why I'm asking is this kind of screening helped my 76-year-old mother.
Oh, wonderful.
And yes, because I'm an engineer by profession, but health education just drives my adrenaline. So anything about health, I jump on it and I read. And with the knowledge, I was able to pursue doctors to run these tests. And of course, she was able to come out of heart failure, which if we had not seen it earlier, it would have been deadly. So it would be nice to actually screen for inflammation markers because the CBC doesn't really give you the broader picture.
Yes.
So if it's something that you don't do, and also now these days they have the lipoprotein little a, which also carries very huge risk in terms of cardiovascular disease. So it's just a suggestion. So that's my take on that.
Mr. Yanka, we need to employ her to add to our list of knowledgeable people.
She should probably speak on the next part 3. It looks like we have to do a part 3, looking at the interest we are getting.
Yes. So she hit the nail. Yes. So she hit the nail right on the sword. So if you come to my clinic at Okponglo, there's no way you walk away without us knowing your CRP, because we're serious at Okponglo. If you come to Yaba Medical Services, you're definitely going to get a CRP in one way or the other. But we're very selective in administering these tests because sometimes it can reveal so many things that if you're not ready to answer the questions, it can lead to a lot of distress. But definitely the risk factors that were mentioned before, the age, the family history, the modifiable risk factors, they're not enough to explain certain things. Why is somebody who grew up in the same village will have diabetes and the other person didn't have diabetes? So sometimes there are novel markers that she mentioned that we can use to detect certain high-risk individuals. So if you come to our place for evaluation, and I actually mentioned that I'll be sending a form out for people to get tests done. CRP is one of them, okay? So if you do CRP, basically CRP is C-reactive protein or ESR. Most of you are familiar with ESR. The problem with ESR is not very sensitive, but it is still used. So you can do your ESR and get your CRP. Clear-cut example is somebody has a cough. We're not sure whether it is just a minor viral illness or it's TB. The person is losing weight. If we suspect it's TB, the CRP will be so high, ESR will be so high, it's unbelievable. So that immediately tells us there's something going on seriously. Somebody has arthritis, and you think that it is not just regular arthritis. Remember, when I say regular arthritis, is age-related overuse. All of us will get it. Overuse arthritis is not inflammatory, it's just overuse. The inflammatory arthritis like rheumatoid arthritis, psoriatic arthritis, uric acid related arthritis, they will cause the CRP to go up, and then the ESR will go up. So those are markers we use. So thank you for bringing it up. So that means that when you go to your doctor, try to engage the doctor very well, and then they can help you go through some of this. How's your mother doing? She's okay, right?
Oh yeah, she's doing pretty good. Pretty good. But just one thing, I think the CRP there too, there's high sensitivity, which is more accurate than the regular CRP. And also with that, when you have that and you have the homocysteine, it actually gives you a better picture, and interleukin 6 and all that.
Right.
Those are all key inflammatory.
Great. Wow, wonderful. She is knowledgeable. Good. I'm proud of you. Okay.
Yes,
then we had
Mr.
a question from Mr. Ben, right?
Yes, Ben Nobia. Ben,
Yeah.
ask your question now, please.
My question is, while doctor was along his lecture, he said if you take wine, you should not take paracetamol. Or I'm sure. My question is it only paracetamol or any painkiller?
Okay. So don't take me to court. Some people use wine to drink their medications. I know one particular person.
Prof, hold on a second. I want to be a bad boy. What is the question behind the question?
Okay, the question behind the question.
No, I'm asking him, not you.
Oh, okay.
No, the question behind the question is that sometimes if you are tired and you take a shot of whiskey, you're okay.
Yes.
So you don't even need
Okay. All right. So now
No.
that you have put it in context,
Yes.
Prof, please answer the question.
Okay. So yes, it is those who overdrink, do alcohol to excess that we're talking about, because alcohol is broken down in the liver, and there are two big organs. Actually, I always say there are 5 big organs that does not like alcohol. Number one big organ is your family. Your family doesn't like alcohol. Okay, it causes problems in families. Number 2 organ is the brain. The brain does not like alcohol. It causes memory. Apart from the acute toxic effect, it can cause long-term problems. The liver, obviously we know about the liver, but the biggest one is the heart. The heart does not like alcohol. The heart, the muscle becomes so weak and flabby when you take too much alcohol. The last one is the liver that we know. So the liver also is a place where paracetamol can be detoxified. And too much paracetamol is a direct toxin to the liver. So if you drink a whole lot and you take paracetamol, the chance that your liver can be injured is higher. But if it is just 1 glass of beer and you've taken your paracetamol in the morning because of waist pain, that is okay. But remember, paracetamol, if you start going more than 6 tablets, meaning the 500 milligram pills, that's 1,000, you're exceeding the threshold. Some places, they've cut it to only 4 tablets, 4 tablets of the 500 because of the toxicity. But the textbook says you can take 8 tablets. That's 8 times 500. That is allowable. But remember, the less, the better. So pain medicines, the fact that the doctor said take it 3 times a day doesn't mean you should take it 3 times a day. If you're not in pain, don't take the medication. Okay. Apart from alcohol and paracetamol interacting, alcohol can also interact with other pain medications like tramadol, like Doretta. Doretta has both paracetamol and the tramadol. So think about that. The alcohol can also interact with codeine, which is a very strong pain medicine that we use in Ghana. Or morphine. Morphine is very, very potent and it can interact with alcohol. So it's not just the paracetamol. The paracetamol is particularly to do with the liver injury. So the more you drink, the less you should be taking paracetamol. Or you have to stop drinking and take your paracetamol. And check your liver regularly. Check your liver. function. Is that okay, my brother? I owe you a call.
Exactly, ma.
Yes.
Thank you very much, Prof. Any more questions for Prof? Well, Prof, whilst the members are putting their questions together, on a sidebar, somebody was asking, you talked about diabetes as one of the issues. So the question is, how is diabetes related to the heart? And
so
is diabetes a lifestyle disease, or is it a genetic problem?
Okay. I'm not a diabetes specialist, but I know enough of diabetes to know that it is one of our headaches, especially in Ghana. It's becoming really a nuisance. And I've had occasions to counsel a lot of retirees who previously were not diabetics, but came in diabetic in their 60s to 70s. So there's that age-related diabetes that we're seeing, which is most often a lifestyle problem. But obviously, there are a lot of things that have to do with diabetes, in that it has to do with regulation and control of sugar. There is one condition that is the type 1 diabetes, where it happens earlier on in life. The pancreas is not doing what it's supposed to do, and they have to be on insulin for the rest of their life. But most of us develop the type 2 diabetes, which by and large is equal to lifestyle, weight gain, stress, inappropriate dishes with high sugar content, inappropriate behaviors, too much beer. Remember, beer and Guinness has a lot of calorie. Inappropriate use of sweetness, sugar, honey. We have examples of patients who tell, avoid sugar, but we didn't tell them the whole story. And then they stopped the sugar. They did very well, but guess what? They're now loading down honey. And then they come back with DKA. That means diabetic ketoacidosis. The sugar is too high. So it's very common. So sugar and honey are the same. By and large, they are the same. And some people feel honey has more sugar than sugar. I don't know. I don't know if that can let you understand what I'm talking about. But diabetes leads to increased sugar in the blood. Increased sugar in the blood is good when you're hungry, but over a long period, it poisons the body. It gets into the cells, the blood vessels, into the brain cells, into all kinds of areas. It's not supposed to be there. It's supposed to be there to be used as an energy generator. You remember, the body uses fuel. And our number 1 fuel is sugar. Number 2 fuel and number 3 fuel. Number 2 is fatty acid. Okay, so that is why when somebody is obese and goes to the hospital and doesn't get the food they're eating, leave them there for a month. When they come home, they have lost most of their fat because it was consumed, right? It was turned back into sugar and used to heal. But when the body is starved, it can change from sugar usage to fatty acid usage. And then when things are really bad, it changes to even a very dire fuel agent called lactic acid and other agents. So the body prefers to use the body prefers to use sugar as its number 1 agent. But too much of this pollutes the system. How is it related to the heart? The heart pumps the blood through the vessels. The vessels supply blood to everybody. When the vessels get affected by this high sugar content, they begin to become stiff. And then you start having deposits of cholesterol and you have atherosclerosis. Number two, atherosclerosis in the heart, muscle arteries are called coronary arteries, leads to heart attacks. So the heart can damage the vessels supplying the legs, supplying the brain, and then by too much high sugar content, these vessels in turn damage other organs. The sugar content will damage the vessels that supply the kidneys. By so doing, the kidneys get damaged. The same method it does to the vessels, it does to the eye. And so the sugar content affects the vessels, high sugar content. So diabetes and the heart are really not the best of friends. So we used to be taught, and it's still the case, that all diabetics are considered high risk until proven otherwise. So anybody who has high sugar, we try to screen you with all the tests that she mentioned. We try to make sure your cholesterol is down. We make sure you don't have CRP. We make sure you don't have coronary artery disease by doing calcium score. We make sure your blood pressure is very well controlled. Otherwise, the more of these factors you have diabetes, you have high blood pressure, you have high cholesterol, the effect on your body is additive. And actually, it is very multiplicative. So it can get worse. That if you have diabetes, in addition, you have high blood pressure, you have high cholesterol, the chance of you coming down with a heart attack is very high. The chance of you having heart failure is very high. The chance of you having peripheral arterial disease, impotence, stroke is very high, and kidney injury. So diabetes is actually sometimes considered as a heart attack equivalent, coronary artery disease equivalent, sort of, because when you have diabetes, the sugar really leads to problems. That's how they're related. I hope I've answered. I've gone round, but
absolutely.
The point is that too much sugar poisons the vessels, and then the vessels become stiff. You get cholesterol, can lead to heart attack, stroke, kidney failure, eye failure, blindness, and other things.
Thank you so much, Joe. Another Vera's hand is up again. Vera, ask your question, please.
Doctor, I think you did a very good job in connecting the diabetes to heart disease. And I want to add one thing. Our standard, typical Ghanaian way of eating, we eat too much refined carbohydrates. And I'm just adding to what you said.
Yeah.
With the overconsumption of the high refined carbohydrates, this turns into fat. And this fat, converts into triglycerides. And we know that triglycerides is where the problem is, where the main fatty carbohydrate stores. And when the body stores the triglycerides, that's the fatty carbohydrate in the liver, there's an overload of triglyceride which turns into VLDL. And this is what penetrates into the arteries and causes problems. So when the arteries causes problems, we have the LDA, which does not penetrate, but the VLDL penetrates into the arteries and also affects the endothelium lining. Mm-hmm. So with what you described, diabetes and heart disease, I think sometime from the early post-COVID, when you look at literature, they classified type 2 diabetes is considered heart disease when you have that.
Exactly.
So our way of eating, overconsumption of high refined carbohydrates, we should look into that.
Yeah.
Thank you.
Can you give an example of the high refined?
We're talking about rice. We're talking about these days, we are trying to gravitate towards standard American way of eating. I heard KFC was having some sales and people were jumping on it like crazy. You are eating fast food. This is processed food. It's junk. When you eat like a standard American diet, of course, you're going to end up with standard American disease. Indomie. This is highly refined carbohydrates. spaghetti, all those noodles, they are highly refined, highly processed food. There's no fiber in it.
Yes.
When you are eating, you want a food with fiber.
Exactly.
But these days, because of lifestyle, we think we are rich or we have arrived. We are gravitating towards fried rice, jollof. All these are refined carbs and heavy deep fried food. Deep fried food are artery clogging foods. So our way of cooking, we should go back to our grandparents' era, where your grandmother would not going to eat Indomie. Your grandmother is not going to eat pizza because there's no nutrition in pizza.
Exactly.
Zero nutrients in pizza.
So a term that you should also think about, and she mentioned it but didn't bring it completely out, is caloric content. So the caloric content is how much sugar do you get from a particular type of food, right? So if you read about it, all the foods that we eat, especially banku, if you look at banku, the way we have refined banku, the olden days, when you eat banku, I always say this and my wife will be on my neck. When you eat the olden days banku and you go to toilet, you don't have problems. You eat today's banku, you're going to be struggling to go to toilet. That's the difference. The olden days banku, we have to go back to it because it is made in such a way that it takes you longer to process. You still have fiber in it, but we've refined it with either konkonte, cassava powder in there, which is very high in caloric content. So the other thing that we're doing that can increase diabetes, not the man, maybe not the woman at your age, but a young woman are using steroids to make their skin look better. And this is something that we are beginning to notice. Steroids, if you take steroids either by skin application or by oral application in consumption, you increase your risk of diabetes. And then by the time you are 60 years old, the beauty is gone, but you're now going to contend with the consequences of that high steroid in your body. Now, if you're giving steroid for a purpose, normally we don't want you to take it too long. And if you're on steroids for a long period, the doctors always monitor you for sugar, for diabetes, they monitor for osteoporosis. So steroid use is part of it. The type of food we eat, the very fine imported polished rice has too much sugar. We are better off with the local parboiled, hardcore grains. But again, is it feasible? Because which one is cheaper and which is available? So Indomie has become the staple for a lot of young people, but they're just buying diseases for the future. Now, as you're a young person, you may be able to consume everything you want, but just know that you're burning down problems. So when you're 45 to 50, your blood pressure is going to go up. Your cholesterol has already started jacking up your arteries. By the time you're 50 and you're becoming the medical director or you're the director of procurement and you want to finish your 10 years, then your sugar is going up. When you finish 60, everything goes down because you have burned your system. So the young people, we really have to let them know that consuming these fast food is not the best for our future.
Thank you very much. Emmanuel, your hand is up. Emmanuel Randolph. Unmute yourself, please. Emmanuel Randolph, kindly unmute yourself. Okay. Yeah, thank you.
So the sister talked about COVID-related diabetes. I got given some steroids during the COVID time. I had COVID for almost 21 days. And I was one of those people considered at the time as having related conditions, so I'm hypertensive, and then I got COVID. And in treating me, at a point I was put on steroids.
Mhm.
The doctor mentioned to me that this thing I'm giving you will set you free, but afterwards you have got to deal with the sugar. And since 2021, I've been dealing with it. I was initially put on metformin. This year, it's been changed to Gavesmet. The Gavesmet is helping manage it, but I've always been swinging between the 6s and the 7s. So I thought I should mention this because it was also raised. So I'm having to deal with the condition now because I was given steroids during the COVID era. Thank you.
Yeah, I'm sorry about that. Yes, it's a very known fact that actually some people believe steroid is the best medication for a lot of things. You name it, but it has too many side effects. And we have steroids. We produce our own steroids from the adrenal gland. But certain instances, we need externally loaded steroids to overcome a system, to overcome a challenge that we cannot master our own steroids. So in your case, at that time, we didn't know what to do with COVID, and we even had problems with what was the best amount of steroid to give to the COVID patients. Everybody had their own ideas, everybody had their own theories. So, but I'm happy you're able to contain it with the Galvosmet. It's not easy, and Galvosmet is expensive. That you're doing that, and you monitor closely, make sure the sugar is tested regularly, and then check all the complications that can happen with the diabetes. Check your kidneys regularly, check your eyes regularly, let them scan your heart, make sure there's no any plaque building up. Knowing that there's plaque building up doesn't necessarily mean that's the end of your life. No, it is the time to take action, to make sure that we monitor you closely. Maybe if you're not taking aspirin, start taking aspirin, all of this. So I'm happy you brought it up. But some side effects of medications can be very, very serious. Yes.
Thank you. Prof, someone else sent me a message that a critical thing that you've spoken about, the medications and their side effects, in particular, the drug interactions and the adverse reactions. And then also the thing you mentioned about losartan potassium or something, the ACE inhibitors or potassium.
Yes.
Can you be kind enough to go over those points again as we get to the end of our evening discussion?
Okay.
So,
yes. So
the medication and the side effects.
Right. As we age and we take medications, sometimes it's not just one medication that will take care of everything. And even if you are taking one pill, for instance, Galvosmet. Galvosmet is one pill, but it's two medications laced into one. So as we take these medications, we will come across problems with the medication by the natural fact that they are chemicals. And all chemicals we consume come with a certain amount of risk. That is the side effect. And usually the side effects are printed because they tried them and they found out the common side effects and they will list the common side effects. If you want to find all kinds of side effects from medication, you'll find it. But usually it's the common ones that are listed. And those get worse as you take more medications or you take multiple medications that interact. So the side effects are usually expected, and sometimes they're dose related. The higher the dose, the more the side effects. A clear example would be amlodipine. Amlodipine is the commonest blood pressure medication used in Ghana, and actually I think the whole world. By common side effect is leg swelling, right? So some people, you give them amlodipine, they're fine. Other people, they take amlodipine, their legs begin to swell. The higher the dose, the worse the leg swelling. And some people, they don't even need to take a high dose and the legs will swell. So if it's due to dose, we'll reduce the dose. And I normally like to combine certain medications. My patients say, you're giving me too many medicines. I say, yes, it's better to have little of each, getting the benefit from each medicine, than to have one single one that can cause a lot of side effect. Drug-drug interaction is when one drug potentiates the effect of another drug or downplays the effect of another drug. So I gave you example like warfarin or something like the blood thinners, right? So the blood thinners, warfarin is one of them, but the newer ones are called Xarelto, Eliquis. They have newer names. The generic ones have so many different names, but they are trade names, their generic names are rivaroxaban and apixaban. These medications, when you take them, your blood is going to be thin. That is granted. If you take ibuprofen, it influences your stomach lining to be very aggressive. You can have gastritis, and that way you can easily bleed. Aspirin is an antiplatelet, so it also causes bleeding. So if you take aspirin for a long time, your chance of bleeding increases. So if you take that together with apixaban, your chances of bleeding goes high. So anytime you're giving a new medication, try to find out, is it going to be working with this medication? And if the physician has time, most often he will tell you. If he doesn't tell you, the pharmacist is supposed to do their work. But most often the pharmacy is not there. It's a technician. You go in there, they throw the medication at you, buy one pack, go home. But the technician and the pharmacy is supposed to tell you. And actually, in first wells, let me use that term because that's what we use. First wells, when a doctor writes a medication that has a serious side effect or obvious drug-drug interaction, he won't even get home without the pharmacy calling him, okay? Because the liability is not just to the doctor, it goes to the pharmacist. So the pharmacist will call you and say, Dr. Kama, you wrote warfarin and the patient is on aspirin and the patient is on apixaban. Do you still want me to go ahead? And everything is recorded. So if I say yes, he's recorded it. If the patient goes down with bleeding, it's not coming to him. He called me to ensure. So there's always check marks to make sure that we're not doing the wrong thing. But having said that, you on your part should also go to Google. And there are websites I'll share with you. For instance, the QT prolongation medications. There's a website that can tell you, you just put the medication there. Does it prolong QT? It will tell you. But the fact that it prolongs QT doesn't mean that you shouldn't take it. Okay, just be aware that if you're taking medication that prolongs QT, and you take another medication that also prolongs QT, then you have double whammy. You're going to have two effects. So the ACE inhibitor, losartan, these are very good medication for blood pressure, very good medication for kidney problems, very good medication for diabetics. And so when you have a patient who has diabetes, Ryan, let me call you right back. I'm giving a talk. Sorry about that. If you have a patient with diabetes and high blood pressure, it's not uncommon to have the person being on losartan. But when I mentioned losartan potassium, what I meant was that losartan, most of these medications do not come by the name alone. There's a compound. It's either a salt or a double compound or something like that. So losartan commonly is linked with potassium. So you see losartan potassium. But losartan and ACE inhibitors, lisinopril, enalapril, captopril, All of those are in the one family that affect the kidney in keeping potassium. So ACE inhibitors are lisinopril and enalapril. ARBs are losartan, irbesartan, Atacand. Most of you take a lot of Atacand. That's candesartan. Those are ARBs. These interact to increase. We never give losartan and lisinopril together. We never do that because then the interaction is not good for your kidney in that the potassium is going to go up. We never give this with potassium tablets unless the person is monitored. Unless the person's potassium is so low, we don't give them with potassium because the potassium can go up. If we give it with potassium, the doctor says, go inject your kidney function in 2 days or 1 week. We also are cautious with losartan and lisinopril together with spironolactone. Spironolactone is a water pill. Unlike other water pills that take out potassium from the system, spironolactone keeps potassium. So if you're taking spironolactone, your potassium can go up. And so when you're on losartan, which can make your potassium go up, and you take spironolactone, the chance of you getting hyperkalemia is high. And hyperkalemia is not good for your heart. It will stop your heart. So that's the drug-drug interaction. So occasionally, kidney doctors will give somebody lisinopril, even though the kidney function is so bad, because they are monitoring, they are watching the kidney, they know what they're doing. Only those crazy specialists do that. But all the public, in regular doctors, we stay away. Sometimes I give, most of my heart failure patients are on spironolactone and losartan and lisinopril, but I monitor their potassium, because you need those medications, and we don't give you too much of each of them. We'll make sure we balance it. So look up some of the websites that can give you some information about drug-drug interaction. Look up some of the side effects on the medication. But the best thing to do is to ask your doctor, what is this medicine for, and what should I expect? What are the side effects? He will mention, oh, you may feel dizzy, your blood pressure might go down. Then you go home and say, okay, he gave me some, but let me also find some. And then you become more educated on your medication. So try to school on your medication. School on your medication. Just like when you go to a bank, you know everything about your account. But you go to a doctor, you don't know a single thing about the medication. Okay. So try these days, write them down, and then have your children print them. Okay, they will type. And these days, you can even speak to your phone and to type it for you. And then you text it to yourself. You have your list of medications. Yes, that's very, very important.
Thank you so much. Incidentally, Brother Kofi Adega has also sent some interesting comments in the chat room. This clearly shows that the topic at hand has been very illuminating. But all too soon, time has caught up with us. When the evening is going sweet, we find a reason called time to abide by. And so the evening has drawn to an end all too soon. And please, Doc, Prof, if you can have your closing words on the topic as we close out. It looks like we may, looking at the topic, it looks like a number of new issues are coming out which may affect other parts of our body. Based on the linkages that you brought out today, we may want to maybe spend some time looking at some pharmaceutical angles to the issues you brought on drugs and medications and how they impact us broadly and so on and so forth. But let me, on behalf of the 60 Plus team, thank you so much for sharing this evening with us. Your parting words, please.
Okay. So thank you very much for having me, and thank you for listening and the good discussions. There are a lot of questions that have been posted and a lot of information shared. the dynamics currently going on, the paradigm is towards personalized medicine. And what do I mean by personalized medicine? Each individual is different. Everybody is different. So you wouldn't be surprised if your doctor says, for you, your cholesterol is too high because yours is 5, but your friend is 6. And he didn't say that to the same person because for you, he's trying to personalize it to you. And we are realizing that the risk factors are also changing because now there have been so many tests, there have been so many research going on. There are risk factors that we used to use. The traditional risk factors that we used to know that cause heart attacks were age, gender, and the type of chest pain, right? But we realize that these do not rhyme very well. Sometimes we're getting young people with heart attacks. Why? Why are they having heart attacks? So inflammation is becoming a problem, exposure to chronic infections, exposure to certain chemicals. So, but to do all these tests is a lot of money. So that's why we're careful. And sometimes the test may come out with a result that you can't interpret it. So before you go chasing after a lot of tests, have a candid discussion with your doctor to say, which one should I do? Should I open Pandora box or I shouldn't open Pandora box? Because you go and open that Pandora box, you can't go back. And you will spend $1 million and you still haven't gotten an answer. So you have to be selective. The other thing we should avoid is hiding medication for other doctors. Okay. Definitely, if you come to our clinic, we are not shy knowing who else you saw. We're not going to, and we actually call them. We call them, oh, don't call him. No, he would think, no, I'll call him and let him know that you saw me. And this is what we discussed. You're coming back to see him because that's your primary doctor. So that it's not that we're stealing you from somebody. So it is very good communication when the doctors communicate and talk to each other about particular patient, especially as you get complicated and you're seeing multiple doctors share information. It's difficult to have Dr. Palu and myself for heart, Dr. Palu for brain, and then Professor Palu and Professor Vincent Boema for kidney. You can't get us all together in one room to discuss you. But you will be the point of contact. When you go to Dr. Palu, Professor Palu's clinic, and he see you for your brain things, let him know what we're doing. Same, you go to Prof. Vincent Aboima, you let him know what you're doing. That way, we can share information. And primary care physicians are not utilized. We tend to use a lot of specialists. Sometimes the specialists don't know a thing about primary prevention. So still keep a regular doctor who knows all about you. At our facility, we provide both primary care and specialist care. Some people don't understand that that is the double whammy we give that people like coming to our place. Because when you come there, most often you get 3 visits in one setting. People don't understand. But those are the things we can do to help people. Because when you come into that visit, you come, we evaluate your primary care, we give you specialist care, and then we test you right there and then and give you responses before you walk out. That is 3 visits in one sitting. You can't get that in most places. So be very proactive and ask appropriate questions. Don't be intrusive. Be respectful of the doctor's time. And then write things down before you go to a doctor so that when you sit down, you have your list in front of you. And sometimes don't get angry if he says, I'll call you later. Just give him time. Let him answer the question. Medications are going to be our friends as we get older. So don't shy away from them. Know that they can cause side effects. Know that they can interact. Know that they can cause sudden, unexpected side effects, adverse reactions. So anytime you start taking a new medication, check yourself. Make sure you read about the side effects. And then with time, you can know the medication very well. I'm hoping that this talk has been able to stimulate all of you to look forward to living to 100 years, and we have to work towards that. Thank you.
Doc, before you go, this is something that we normally don't do, but it seems that the comments, points raised by Kofi Adega, if you can just spend 2 minutes, so members are listening to us, if you can indulge us to have Kofi Adega's points quickly discussed by Prof in about 2 or 3 minutes.
Okay, let me read the first comment. Kofi Adega, thanks so much for your insightful comments. So first, he says, just turn in, I may miss the first part of the talk. I wish to submit that insulin resistance underlies a lot of chronic diseases, including diabetes and hypertension. However, insulin rarely evaluated in modern day lab works. My second submission is that cardiovascular inflammation is more relevant to heart disease than cholesterol. Then the second portion of his talk, his comment, also the new guidelines is prioritizing ApoB and Lipo-A over LDL cholesterol on its own. It's no more the cholesterol concentration by its density. Are these being implemented in Ghana at primary care level? Also, the new kidney disease guideline says cystatin C EGFR be used in tandem with creatinine EGFR. Is this being implemented in Ghana? I'm keen to know your views, Prof. Akama, or any doctor reading my comment, my message. So this is, I think you may have missed the young lady's comment she made earlier, but you are on point. You're on point in that the guidelines are changing, and medical care is becoming more personalized, and more risk factors are being co-opted in to optimize care. Previously, we used to use a cohort-derived equation to risk stratify patients. If you look at the current guidelines, which I believe most of my colleagues are using in Ghana, the PREVENT equation puts in a lot of things, okay, and adds more credence to who is actually at high risk and who is not at high risk. In addition, the new cholesterol guidelines, you won't believe it, but we all must have low cholesterol, okay? So when you go to the lab and check your cholesterol, it's no more, or it's within normal range. What is your LDL? What is your total cholesterol minus your HDL? That is the non-HDL cholesterol. What is the number? The target is to bring down the LDL very low. High-risk patient, it should be very, very low, less than 1.5. In moderate risk patients, you might go to 1.8 to 2. In normal people, we don't want it to stay more than 2.5. It should be rated the LDL cholesterol. In addition, your total cholesterol minus your HDL. HDL is a high-density lipoprotein. That is the good cholesterol. So if you take your total cholesterol and you subtract the LDL, the amount should also be very low. Now, you mentioned lipoprotein A and B. These are measured regularly. Lancet does them, Thin Lab, all the other labs, Legon, UGMC lab, Kolebu lab, all these top labs, Metropolis, all of them will measure them. But there is no treatment for lipo-A and lipo-B. So don't get angry if the doctor says, I have nothing to do with your lipo-A. You measure it as a risk modifier, as a risk stratification tool, but we can't treat it yet. They don't have medication for lipo-A. So who are the people? As I said, it's good to check but you have to be careful what you check and how you interpret it. If that medicine, if that lab test is going to keep you awake for 1 month, don't check it. But if you check it, you have to take actionable plan and work on it. Okay. Oh, let's check my EKG. Then we'll check the ECG. The ECG says it's abnormal. You haven't brought it to the cardiologist. And for the past 1 week, you are not sleeping because the ECG says it's abnormal. So yes, it's good to check, but make sure you go to the right person to counsel you, to get before testing counseling, after testing counseling. It's almost like a genetic counseling. So these days, they don't do genetic tests without counseling you. So some of these tests are good to do, but they have a lot of implications and a lot of money can be spent. And some people will say, is it warranted? Should we all be taking the cholesterol medicine or not? But the risk stratification tool makes you know that if I check my lipoprotein A and I check my LDL is too high and my cholesterol is high and my A1C is creeping up, definitely I am a high risk patient. I need to do something immediately. I need to reverse this before I cross 65, before I go to 70, because you don't want to get heart attack. And then you quickly go and get a calcium score. She mentioned calcium score. Calcium score becomes a mandatory thing. And I'll be talking to some of the CT scanning departments in Ghana. They're not reporting on coronary calcium or atherosclerosis in their images. They should start doing that. Okay, you send them for a CT scan, they just report on what you send them for. They are doing something that is not allowable. So the Radiology Society, I'll be sending them a letter that they should encourage their members to report any atherosclerosis found in a patient. That way, we put it as a risk that you did a CT scan for your lung looking for pneumonia. But they also found you have atherosclerosis of the coronary arteries, you have atherosclerosis of your aorta. It makes you immediately a high-risk patient, and then we can manage it accordingly. So thank you for your comments, but these guidelines are being implemented, and definitely the Society of Cardiologists, Ghana Society of Cardiologists, we take things seriously. We adhere to guidelines. We are behind certain things in that we don't have our own guidelines. I'll give it to you. We try to make guidelines, but they're not from indigent data. We copy European guidelines. We copy American guidelines. But we should have our indigent, our native data to say, if you're from Bongo, your risk of getting diabetes is so high. So all Bongolites or Bongo people must be treated accordingly. If we had that, then we can say we have our own guidelines. But we don't have that. We're using European and American guidelines. And you remember last time I said that Nigeria and Ghana are using 140/90 as the cutoff for treating blood pressure. And I said it's too late. If we're waiting for 140/90, that is too late. We should rather go down to the 130/80, which the European guideline says if your blood pressure is persistently more than 130/80, they should risk stratify you. They didn't say they shouldn't treat you. They should risk stratify you. If you're high risk, they should treat you. If you're low risk, they should caution you. So our guidelines have to be really tailored to Ghanaians. Thank you.
Thank you so much, Professor Joseph Atia Akama, who is also the Chief of Cardiology from the Meharry Medical College and the Nashville General Hospital in Tennessee, USA, and is also affiliated with the Yaba Medical Services Center in Oponglo, Accra. He's been speaking on the topic, Holding Your Heart Steady, Rational Behavior, Medications, and Health Actions to Extend Your Life. We might be doing a third part of the health series, looking at some other aspects. It could be Dr. Akama alone or with some other people, or it could be another, and the committee will be looking at the topic again. But also coming up will be an interesting series on cybersecurity. That's also coming up. So watch out for that. And as we've indicated, if you are interested in receiving a copy of tonight's presentation, send an email. Quickly look at the chat box and send an email in the manner prescribed in the chat box. Thank you very much. Have a very wonderful evening. And thank you for joining the 60 Plus group for a fantastic evening. Thank you very much. And thank you once again.
Good night. Thank you.
Good night, everybody.
Thank you.
Thank you. Good night.
Bye-bye.
Good night.
Bye-bye.
Thank you. Mr. Younger, I sent my email the last time, but I never had anything.
Please do it again this time the way I've done, and you'll get it.
Right. Thank you and good night then.
Thank you.